Hello campers, and welcome to the SLM on delirium and the treatment of agitation. Take a moment or two and go ahead and read through this case before advancing to the next slide. So what's going on is obviously delirium, right? This is an alteration of cognition that goes with an alteration of consciousness. As the person's conscious levels go up and down over the space of 3 to 4 hours, their cognition goes with it. And what I want you to think of this is as delirium is the same as acute brain failure. And acute brain failure, much like acute renal failure, acute hepatic failure, is an inadequate or inappropriate response of the end organ, but it's not due to the disease of that end organ. So if you think about the last time you saw someone with acute renal failure, the source of the problem was never in the kidney. It was a heart attack elsewhere, an infection or something like that that caused the kidney to shut down. Likewise, just like acute kidney failure can often have issues with taking days to weeks to return to baseline after the insult, the brain is the same way. It can take days to weeks for the brain to return back to normal cognition even after the insult is removed, and so recognizing this and having some patience becomes key. Delirium is a fairly common experience. It represents 10 to 15% of admissions to general hospitals either come in with or develop delirium as part of that admission. And it tends to preponderantly affect vulnerable patient populations. So the elderly are at high risk, dialysis patients or others with major chronic medical issues are at higher risk, those with obstructive sleep apnea are at risk. It tends to be more common in folks with polypharmacy, and again, by polypharmacy, the literature tends to indicate more than 4 drugs, not more than 12. So pay attention. A lot of our patients, especially on the inpatient hospital services, may already meet that criteria. And the last point brings up a very important point, which is delirium often happens as a result of a last straw phenomenon. What happens is they have this incredible loading, so chronic medical issues leading to multiple medications, and their brain's just barely able to work around all these things, and then the last straw happens. Something like a simple cystitis that can tip them over from functional into this non-functioning cognitive disorder delirium. The sources of delirium are multifold. This is just a brief slide to help you start to think about how broad and diverse the sources of delirium may be. Toxic and metabolic events, infection, lack of oxygen, seizures, structural changes, all have the potential to lead to delirium. This is not an end-all list. There are multiple mnemonics you can find out there on UpToDate and online and all sorts of sources. One of the challenges typically with delirium is that the mnemonics are so long you need a mnemonic to remember the mnemonic, which makes it very challenging because the sources are multifold. So what I encourage you to do, rather than trying to memorize a mnemonic, is rather determine what source you intend to use for your thinking through for delirium. Just like the sources of delirium are multifold, your workup should likewise be rather broad. This is probably a reasonable starting place for trying to determine your source of delirium. Recognize that this is not by any means exhaustive. There are hundreds and hundreds of tests, but at least this gives you the initial screening that may give you some data towards advancing your approach. The other challenge that happens is even when you do a good, thorough workup, the literature says up to a third of patients admitted with delirium have resolution without ever finding a cause. Now that doesn't mean just assume they're going to get better. You have to be aggressive, find a cause, and reverse the cause. But recognize sometimes when you are treating someone with delirium, they get better all by themselves. despite this aggressive workup, which may reveal no good source. Just as you're looking for medical causes for your delirium, you need to look at whether you have done it to them yourself. Iatrogenic causes, especially from medications, are quite frequent. The list here gives you some of the more classic problem drugs. So analgesics, including opiates, are notorious. Antibiotics, especially the quinolones, which are cytochrome P450 inhibitors, often shift the body's ability to metabolize its normal medication profile, leading to delirium. Remember back to 2 slides ago when I talked about the last straw phenomenon. Sometimes the quinolone is that. It doesn't cause the delirium, but because it upsets the normal pharmacokinetic and pharmacodynamic structures of the body, it can cause delirium. Dopamine agonists, and especially hypnotics, what you also have heard referred to as benzodiazepines, become incredibly common sources of delirium. The next phase of this SLM talks about the management of agitation, and I present it not because all delirious patients are agitated, but agitation is not an uncommon finding in delirium. So the good news is as we approach the management of agitation, your patient doesn't have to be delirious. They can be agitated and have clear cognition, but this at least gives you some ideas about ways to approach agitation, whether in the demented, the delirious, or otherwise. The first process is don't just do something, stand there. That means try to do as little as possible, especially from the pharmacologic side of the house. Non-medications or non-pharmacologic treatments are always the choice of preference in delirium. And so I give you some here. So reorientation becomes important, and that's not questioning. That's not, do you know who you are, where you are. It's coming in and saying, you're at Greenville Memorial Hospital. Today is, the 1st of April, 2017, whatever it may be, and helping them understand what is real and where they truly are, and getting them grounded into their orientation, rather than asking them several questions, which sometimes causes confusion. The ability at Memorial to use a sitter for your delirious patient to try and minimize agitation. That may help to keep them in the bed, leave the NG tube or the IV tubing alone without having to resort to using medicines or restraints to keep themselves safe, as well as keeping your treatment options open and safe. Recommend keeping the shades open, which is a challenge, but it is so much easier when they have natural sunlight to recognize day versus night. Do your best to increase their activities during their day and help them regulate their sleep by having them up in the day as much as possible. Patients who have more day-night confusion tend to have a much longer course in their delirium. So, recognizing the caveat that opens this slide and my previous slide's discussion that the first option is always non-pharmacologic, let's talk a little bit about pharmacologic opportunities. So my first choice is to use low-dose, frequent-dose antipsychotics. Haloperidol is by far and away my first choice. The reason is it's a pure dopamine antagonist. All it does is D2 antagonization, which means it doesn't hit a lot of other neuroreceptors in the brain, some of which are more linked to delirium than others, such as anticholinergic and antihistaminic. It does have QT prolongation as a risk, but it's no different than any of the other antipsychotics for QT prolongation, period. And so, as such, is no more or less safe than any other option presented. It's triple-rooted, PO, IM, or IV, which allows you to meet the patient where they are. If they're able to take PO, that's good, but if they have already lost control and require something otherwise, it's very easy to do. And it has a broad scale of dosing, anywhere from half a milligram up to 10 to 20 milligrams at a dose, depending on what you're trying to treat, the severity of agitation. that allows you to be able to give a half a milligram to your 90-year-old, 85-pound little lady, whereas it allows you to give a very hefty dose to your 350-pound offensive lineman. If your attending has concerns about haloperidol, ziprasidone may be a good alternative. It's a bit dirtier because it does hit multiple other receptors, 2 or 3 serotonin, a little bit of antihistamine, a little acetylcholine, but it tends not to cause much problems with that, and it avoids the antihistaminic pretty well. Downsides are that it only goes as PO or IM, so you don't have IV formulation, but it still does have a broad scale of dosing, much like haloperidol. Finally, let's talk about some of the things to avoid in management of agitation, at least pharmacologically. So you wish to avoid low-potency first-generation antipsychotics like thioridazine. They're fairly anticholinergic and antihistaminic, and both of those receptors in activation have a tendency to cause confusion all by themselves and obviously have the potential to prolong delirium. Benzodiazepines cause delirium all by themselves, and there's at least a couple of good research studies showing that the use of benzodiazepines may prolong delirium as well. Now, the exception to this rule is if the patient's delirium is due to substance, then benzodiazepines actually becomes a very good choice and potentially better than haloperidol. So if you look at someone who is delirious due to methamphetamine intoxication, or due to alcohol or benzodiazepine withdrawal, then benzodiazepines may be a very good choice for the control of their delirium. You want to avoid antihistamines, and though there are very few problems with selective H1 and H2 blockers like cetirizine, we have a tendency to give patients Benadryl or other drugs that are fairly antihistaminic, trying to get them to go to sleep at night, and so you have to watch that they may cause more problems with confusion and therefore agitation. Lastly, the anticholinergics can cause delirium, can cause worsening confusion, which may lead to agitation. And the problem here is that we use anticholinergic drugs a great deal in symptomatic treatment of other things. So I gave you a short list of antidiarrheals, muscle relaxants, things like that. But a lot of things have the potential to have anticholinergic effects, and so you have to be very careful with the medications you're offering your patients, especially PRN medications that may be standard or considered standard by your system, such as antidiarrheals, as I mentioned. That's all I have to present as far as delirium and the treatment of agitation. As always, if you have questions, please take this up and discuss it with your attending. Take it up or research it for yourself in UpToDate or your own online sources that you find most beneficial. And obviously, you can feel free to reach out to me as you need to. Thank you, and good luck.